Bismillahirrahmanirrahim. Our topic today about acute liver failure. Actually, this syndrome is a heterogeneous syndrome, which means it has different etiologies, but all have the same presentation. Although uncommon, but it is very serious. And we know why very serious. Because no intermediate solution. For acute liver failure, the patient either to be diagnosed and saved with complete recovery or to die. No intermediate solutions. Let us go. By definition, acute liver failure, as we mentioned, is a crash, sudden collapse in a patient with healthy liver. All of a sudden, acute shutdown in the liver function. It is a dramatic clinical syndrome in which a previously normal liver fails within days to weeks. There are different terms, classifications, and definitions. All of these terms now has been replaced by the broad term acute liver failure. But I'll give you some ideas about these terms because you may find in the literature or the old texts such terms to be able to understand. Whatever the term use or definition, the syndrome is defined by 4 criteria. There is element of encephalopathy, mental disturbance due to failing liver, coagulopathy, jaundice, and the 4th criteria is very important, that in a patient with a previously normal liver. This is to differentiate this category from another category, which is acute on top of chronic liver disease. This is another disease, another issue, another topic. So our topic today will deal with patients who develop encephalopathy, coagulopathy, and jaundice in a previously completely healthy and normal liver. The first term used in 1970 was fulminant hepatic failure. It was defined as potentially reversible condition. As I mentioned before, there is a possibility for complete recovery, although small, but it may recover completely or die. As a consequence of severe liver injury, encephalopathy appears within 8 weeks of initial symptom. The term fulminant hepatic failure was labeling the patient as fulminant if encephalopathy developed within 8 weeks of the initial symptoms. In the absence of pre-existing liver disease, this is the criteria in all definitions. This was labeled in 1970. Later on, in 1993, the definition was revised, considering that they have noticed that the interval between not the initial symptom, but between the onset of jaundice and the development of encephalopathy may give prognostic clue, may give prognostic index. That's why in 1993 this classification has been suggested. They classified the acute liver failure into hyperacute, time from jaundice to encephalopathy 0 to 1. What mean by 0? That the patient may develop encephalopathy even before jaundice appear on his eyes. You know, clinically, jaundice will appear if bilirubin reach to 3 mg per deciliter or more. So bilirubin may increase but not reach 3, and the patient develop encephalopathy before this. This is what we mean 0 to 1. This is called hyperacute. If encephalopathy developed within 1 to 4 weeks from jaundice, this was called acute. Subacute from 4 to 12 weeks. As we mentioned, they select the time from onset of jaundice to encephalopathy because of its prognostic value. In hyperacute, survival rate without emergency liver transplant was good. It has good prognosis. But in subacute, it is poor prognosis. I mean here, prognosis in the absence of liver transplant. The best example for hyperacute is paracetamol toxicity. The best example for subacute is non-paracetamol drug-induced acute liver failure. On this basis, the EASL, the European Association for Study of Liver Disease, adopted this classification, they consider weeks from development of jaundice to development of hepatic encephalopathy, from 0 to 1 hyperacute with good prognosis, from 1 to 4 acute with moderate prognosis, from 4 to 12 weeks poor prognosis, and this is called subacute. However, the condition is considered chronic liver disease if exceed 28 weeks. Before 28 weeks, it is called acute liver failure. A definition similar to this has been adopted also by the American Association for Study of Liver Disease, which identify acute liver failure by evidence of coagulation abnormality and any degree of mental alteration, encephalopathy, in a patient without pre-existing liver disease and with an illness of less than 26 weeks duration. This is the commonly used definition now as an umbrella to cover all previous definitions. So acute liver failure is defined by evidence of coagulation abnormality and any degree of mental alteration, encephalopathy, in a patient without pre-existing liver disease and with an illness of less than 26 weeks duration. And now to the causes of acute liver failure. As we said, this is a heterogeneous syndrome. Different causes can underlie different causes of liver disease, like viral hepatitis, acute hepatitis A, acute hepatitis B, acute hepatitis D, E, even non-hepatotropic viruses like cytomegalovirus, herpes simplex virus, even seronegative hepatitis. Apart from viral hepatitis, drug-related acute liver injury, dose-related like paracetamol, idiosyncratic reactions like antituberculous drugs, statins, recreational drugs, anticonvulsants, NSAIDs, and many others. Toxins also can cause acute liver failure, like carbon tetrachloride and aminophthalate. Acute vascular insults, acute ischemic hepatitis, veno-occlusive disease, Budd-Chiari syndrome, etc., etc. Other uncommon causes like pregnancy-related liver disease, acute fatty liver of pregnancy, even some metabolic like Wilson's disease may present by acute liver failure. Lymphoma, carcinoma with acute infiltration may present sometimes by acute liver failure. If you look to the viral category, viral hepatitis, what did you miss? What is the HCV? HCV, it may cause acute hepatitis, but it is very, very, very rare to cause acute liver failure. There is a big difference. Our talk today is about acute liver failure, failing organ, not acute hepatitis. Hepatitis does not mean failure. Hepatitis means inflammation, but failure is loss of function. So this is a different issue. When we come to the viral causes of acute liver failure, actually hepatitis C virus is a very, very, very rare cause of acute liver failure. Now let us have some details on the initiating events and their clinical implications. The first group, especially in the Western countries, drug-induced acute liver failure. As you may see in this diagram, most of the cases in the Western countries, especially in the States and UK, are caused by acetaminophen toxicity, paracetamol toxicity. Then some indeterminate causes, 17%, idiosyncratic drugs, drug reaction in 13%, viral causes are responsible for minor sector in the developed countries. If we look to the drugs causing acute liver failure, if you have a look to this list, all these drugs are drugs that we are using every day, like amoxicillin, antibiotic, carbamazepine, Tegretol, antiepileptic, clavulanic acid, augmentin, diclofenac, non-steroidal anti-inflammatory, halothane, general anesthesia, ibuprofen, non-steroidal anti-inflammatory, ofloxacin, quinolone, statins are used for, as you may see, these drugs are prescribed every day. So please, the message to be careful. By the end of the day, a drug is a toxin. If not indicated, don't try it, please. Be cautious, especially in the elderly, as unlike other causes of acute liver failure, drug-induced liver failure arises more often in older than younger patients, especially 60 years old or more. So you should be sure that your drug is indicated and give the proper prescription in the proper indication, please. Regarding acetaminophen toxicity, which is the common example, this is the most popular analgesic antipyretic. The recommended dose should not exceed 4 grams per day. Sustained consumption of 4 grams per day for more than 4 days may cause asymptomatic increase of serum liver enzymes with no evidence of serious liver injury. Enhanced liver injury has been described with consumption of therapeutic doses for symptom relief at the onset of acute liver disease due to other causes, which is very serious because, as we said before, for example, viral hepatitis may present by flu-like attack in the first few days with fatigue, malaise, low-grade fever. Once fever subsided, jaundice appeared. Before jaundice, we may deal with the case as a case of flu and give them paracetamol. So please be cautious. If any patient with flu have some nausea, some vomiting, some upper abdominal discomfort, please have a look to the liver enzymes before prescribing paracetamol. Pre-existing conditions as alcohol abuse may influence the liver susceptibility to lower doses of acetaminophen. Compared with all other causes of acute liver failure, patients who had ingested acetaminophen had higher rates of spontaneous recovery and better outcomes. As we said before, that acetaminophen toxicity will cause hyperacute. The hyperacute causes this very severe injurious agent that will stimulate all the regenerative capacity of the body, have a better chance for recovery, and that's why better prognosis. The other group of causes include viral infections. On top of the list, hepatitis E virus. This is the most common cause of acute liver failure in India, Pakistan, and Southeast Asia. Mortality can exceed 50% if no emergency liver transplant available. The highest mortality in pregnant ladies. After that, coming hepatitis B virus. This is the main cause of acute liver failure in Asia and Sub-Saharan Africa and Amazon basin. It follows only 4% of acute hepatitis B virus. Markedly decrease after vaccination programs. Other viral causes like herpes simplex, varicella zoster, Epstein-Barr, cytomegalo, and parvovirus 19 may present by acute liver failure. As we mentioned before, HCV, alhamdulillah, is a rare cause of acute liver failure. And now to the histopathology in acute liver failure. As we mentioned before, it is sudden collapse. The liver will be collapsed both anatomically and functionally. Hepatic failure, which we mean failure within 1 to 26 weeks of the initial insult. Massive necrosis will happen, shrinkage of the liver, wrinkled capsule, collapsed reticular network, only portal tracts will be visible, massive necrosis as we mentioned. More than a week, if we have a look after 1 week, some regenerative activity may start to appear in the biopsy. Then either complete recovery with complete regeneration or death. Now let us discuss the pathophysiology of acute liver failure. To discuss the pathophysiology, we should rapidly have a look to the normal liver function. Then we will look to the spectrum of functional derangement that will occur if the liver has been collapsed or if the hepatic function has been lost. And lastly, we look at the factors determining the severity and the prognosis of the case, the sequelae of the case. Regarding the liver functions, as you all know, the main liver function include metabolism of the macronutrients, carbohydrate, protein and fat, storage and activation of vitamins and minerals, formation and excretion of bile, steroid metabolism, detoxification of drugs and alcohol, even immune function as an important filter against bacteria and fluid chamber, conversion of ammonia to urea. All of these are done by the liver. So you may imagine what will happen if these functions has been suddenly and dramatically lost. This is the spectrum of functional derangement in acute liver failure, which will include cerebral edema, hemodynamic instability, renal failure, coagulopathy, profound metabolic derangement, and immune derangement, including bacterial infections, fungal infections, and so on. And now, what are the factors which will determine the severity and the prognosis? Actually, it is a matter of balance. The net result will depend on two opposing powers, two opposing factors. The injurious load, the degree of metabolic derangement, endotoxin scavenging activity, and oxygen stress that hit the liver, and the regenerative capacity of the liver. If the injurious load is more powerful than the regenerative capacity, the patient will die. If the regenerative capacity is more efficient and can overcome the injurious load, and complete recovery will happen. Actually, acute liver failure is still responsible for 6% of mortality from liver disease. In earlier reports, mortality was around 85%. However, in the era of transplant, the 1-year survival became 60 to 80% in higher centers. Unfortunately, you may know that although we have good programs in Egypt for liver transplant, but we are doing elective liver transplant. Emergency liver transplant still not feasible in our country. That's why this syndrome is still one of the grave and fatal diagnoses in our country. Now to the clinical presentation. How this patient will present. Actually, you will find the patient will present by a unique combination of often rapidly progressive, severe multi-organ failure with unpredictable complications. Clinical features start by early presentation of acute injury, like any acute hepatitis. Start by some prodromal illness, flu-like attack, low-grade fever, fatigability, anorexia, malaise, non-specific epigastric and upper abdominal distress. Liver size is normal or small, associated with marked increase in liver enzymes, AST and ALT. So this is a picture of acute hepatitis. So at this stage, it is only acute hepatitis, but this will progress to liver failure. That's why here there is a very important message I would like to tell you. All of you, when you be graduated, will be a primary physician in a far village, away, maybe away from the higher centers. When you will diagnose a child or a boy or an adult with acute hepatitis, what is your main target in his management? You know, the management of acute hepatitis actually supportive measures, liver support and bed rest, and that's all. Avoid offending drugs and injurious agent. But the main issue is to decide, is I am facing really acute hepatitis or the condition is progressing to acute liver failure? This is a very important question. From our practice, Usually, I become so astonished when I see a lot of cases referred from my junior colleagues as acute hepatitis, and he is following the patient, for example, for 1 to 2 weeks, and every other day he is doing ALT and SC, ALT and ST, and never requested INR, which will reflect the real function. Coagulopathy, the real function, this is the main synthetic function of the liver. You should keep open eye on INR and other stigmata of liver failure. If INR is stable and the synthetic function is maintained, this means we are dealing with hepatitis. You can assure the patient, assure the family, and keep him. But once the INR as an indicator of synthetic function start to jump up, you should be sure that this patient in the way to acute liver failure, please send him to higher center. This is very important message I would like to tell my junior colleagues. Okay, then the second step, the features of failing liver function will appear: failure of hepatobiliary excretion, jaundice and itching, failure to metabolize toxic substances like ammonia start to have some neuropsychiatric manifestations, failure to maintain intermediary metabolism start to present by postprandial hyperglycemia and fasting hypoglycemia, failure of biosynthetic function, prolongation of the prothrombin time, and increase in the INR. Then after that, the features of other consequences of failing liver on other body systems will appear clinically, like microcirculatory system, respiratory, hematologic, GI, neurologic, renal failure, infection, and electrolyte. And now we will discuss in some details. Failure of liver function, as I mentioned, will present by hyperbilirubinemia, failure to metabolize toxic substances, increase ammonia, hepatic encephalopathy, alteration in drug level and drug metabolism with some drug toxicity, failure of intermediary metabolism of carbohydrate, for example, will present by hypoglycemia after fasting and hyperglycemia after meals, disturbed lipid metabolism, increase plasma free fatty acid, altered arterial ketone body ratio, increased protein breakdown, increased plasma amino acid, and relative decrease in branched chain amino acid. Loss of biosynthetic function of coagulation factors, decrease factor 2, 5, 7, 9, and 10. All of these are features of the failing liver at the level of the primary organ, which is the liver. Later on, the acute liver failure will give its print, its influence in almost every body system, like microcirculatory dysfunction, respiratory dysfunction, infection, hematologic disturbance, circulatory dysfunction, renal failure, electrolyte disturbance, GI consequences, and neurologic consequences. Let us see rapidly. Microcirculatory dysfunction, impaired pulmonary oxygenation of blood, altered oxygen carriage and delivery capacity of blood, altered the ability to deliver oxygenated blood to tissues, impaired oxygen utilization of tissues. Early there is hyperdynamic state, increased cardiac output, increased tachycardia, increased stroke volume, decreased systemic vascular resistance due to increased nitrous oxide, which is vasodilator, then decreased central venous pressure due to peripheral vasodilatation with decrease in venous return. Later on, profound peripheral vasodilatation, failing heart when the heart exceeds the Starling law, hemodynamic collapse. Relative adrenal insufficiency may share in circulatory failure. Subclinical myocardial injury may has its role. Pulmonary consequences. Initially, there is central hyperventilation with respiratory alkalosis. There are some airway problems, mucus plugs, aspiration, pulmonary alveolar and parenchymal processes, pneumonia, pulmonary hemorrhage, atelectasis, pneumothorax, volume overload, heart failure, and adult respiratory distress syndrome. Renal failure is another grave consequence of acute liver failure due to several ways, several method of influencement from the liver over the kidney, like pre-renal azotemia, hypoperfusion, due to increased gastrointestinal losses, inadequate volume replacement, or not only pre-renal, acute tubular necrosis due to volume depletion and iatrogenic due to drugs used, sepsis-related decreased renal perfusion due to septic shock or cortical necrosis or urinary tract infection, then end by functional derangement in the kidney function secondary to acute liver failure, which is called hepatorenal syndrome. Once acute renal failure occurred, this is of very poor prognosis. Hematologic disturbances also alter the production of coagulation factors, decrease all coagulation factors levels except factor 8, because you know all coagulation factors are synthesized in the liver except factor 8. Factor 8 may increase consumption of coagulation factors due to DIC and fibrinolysis. Thrombocytopenia, decreased production of platelet due to bone marrow affection, or increased platelet sequestration due to hyperdynamic circulation and the start of splenic affection, or due to consumption sequestration due to DIC. Qualitative platelet dysfunction, not only the platelet count but also the quality of the platelet are poor. De novo, platelet are asthenic due to renal failure. There is fibrinolysis, decreased fibrinogen, dysfibrinogenemia, and DIC. All of this will lead to hemostatic failure. GI consequences: early there is nausea and vomiting. Late there is ileus due to electrolyte, acid-base disturbance, sepsis, and narcotics. 1/3 of elevated pancreatic enzyme will show, 1/3 of patients will show elevated pancreatic enzymes. Infrequent, clinically significant pancreatitis may be seen. Gastrointestinal bleeding, acute portal hypertension, increased intracranial pressure, coagulopathy. Varices are rare, really. Rare to find varices and bleeding or ascites. Actually, if there is varices, it makes a lot of doubt in diagnosis. Is it acute on top of chronic and there was unrecognized chronic liver disease behind, or is it acute only with varices? May happen especially in subacute forms. Infection, as we mentioned, the liver is one of the antibacterial filters and antifungal filters. Infection usually within the first few days after the onset. Candida usually in the second and third weeks. Most common pneumonia, bacteremia, urinary tract infection, Staph aureus, E. coli, and the Candida species. The fungal infection will increase if there is increase in renal if there is associated renal failure or associated with prolonged antibiotic use or invasive monitoring. High fever, unresponsive to antibiotics should arouse the suspicion of fungal infection. Profound leukocytosis and acute renal failure, you should consider fungal infection. Electrolyte disturbance, all forms of electrolyte disturbance may happen, like hyponatremia, hypokalemia and alkalosis, hyperkalemic acidosis. Later on, hypokalemia may result from GI losses, aggressive diuresis, alkalosis, hypophosphatemia, shift due to glucose infusion, use in regenerating hepatocytes and respiratory alkalosis, worsening of mental status and respiratory failure, hyperkalemia, hyperphosphatemia, hypocalcemia in oliguric renal failure. All forms of electrolyte disturbance may be. Neurologic consequences. Here is a very important difference between the neurologic insult in acute liver failure versus acute on top of chronic that we see in cirrhotic patients. The main mechanism of neurologic insult and encephalopathy in acute liver failure is cerebral edema and intracranial hypertension, while this is very rare in cirrhotic patients. Because of cerebral edema, the encephalopathy in acute liver failure is characterized by seizures, convulsions, and agitations as a features of cerebral edema, while seizures is not a feature in the common patients we see in the world with acute hepatic encephalopathy on top of chronic liver disease. This is very important because it will influence the management. The main mechanism of hepatic insult and cerebral edema in acute liver failure include disruption of cerebral autoregulation due to systemic vasodilators like nitrous oxide, elevated bacterial endotoxins, TNF-alpha, and interleukin 1 and 6. which will cause increase in intracranial pressure, increase intracranial hypertension, and astrocyte edema, cytotoxic edema due to impaired cellular osmoregulation in the brain with accumulation of glutamine in astrocyte. Both disruption of cerebral autoregulation and astrocyte edema will cause intracranial hypertension, which is the most serious complication, will cause cerebral hypoperfusion, hypoxia, ankle herniation, and brain death. Hepatic encephalopathy in the chronic patient is completely different. It depends on ammonia, retained ammonia, endogenously derived benzodiazepine, GABA and glutamatergic system affection, increase circulating endogenous ligands for GABA receptor, ammonia increase affinity of ligands to receptor, decreased turnover of GABA, increased tone of inhibitory GABA, and decreased glutamate. These are the mechanisms mainly responsible for encephalopathy in patient with chronic liver disease. On contrary, in acute liver disease, the main issue is cerebral edema. That's why the management will be different. The management in acute liver failure will be measures to decrease intracranial pressure, like ventilation, and in hepatic, in acute on top of chronic, it will be removal of ammonia, like enema and lactulose, and all the other measures you all know. Now, to the management of acute liver failure. As any topic in medicine, management, when we say management, this means diagnosis and treatment. Like all other topics in medicine, detailed history, physical and mental examination, laboratory evaluation, plus minus liver biopsy. History taking. We will ask for symptoms like GI upset, generalized malaise up to confusion. Detailed history looking for the cause. Actually, you should know your target during taking history and examination. We have three main targets actually from history and physical examination. Number one, to differentiate, is it really acute liver failure or acute on top of chronic liver disease? Because the management is different and the prognosis is different. This is number one. Number two, to identify a possible cause, the initiating factor. If you can identify the initiating factor for acute liver failure, you may have the chance to interfere to suppress this injurious agent. This will shift the balance between injurious agent and regenerative capacity toward regenerative capacity, which will cause complete recovery and will save the patient. So the first target from history and examination to differentiate, is it acute or acute on top of chronic liver disease? The second target is to identify a possible cause, a possible triggering factor. Number three, to monitor the mental status of the patient. Some clues in acute liver failure, history and physical examination. For example, in a trial to reach to the predisposing factor. If you found a patient with encephalopathy with no clinical jaundice in the absence of jaundice, this is mostly hyperacute, which is usually caused by acetaminophen ingestion. At this state, you may give the antidote, which is you may give the antidote for acetaminophen and suppress the injurious agent. If you found, on the other hand, intense jaundice, jaundice out of proportion of the other liver functions, you may think in Wilson's disease. You know why? Because in Wilson's disease is metabolic disease with copper toxicity. Copper will be precipitated in the brain, causing neuropsychiatric manifestation, in the liver, causing acute liver failure or chronic. In the red blood cells, it will cause acute hemolysis. So, if the acute liver failure happen in Wilson, it will lead to increased bilirubin. At the same time, associated with acute hemolysis will also cause increase in indirect bilirubin. So there is two underlying mechanisms. You will find shooting of the bilirubin out of other liver enzymes. Another clue is if you found tender hepatomegaly with ascites. Usually, as we mentioned, in the pathophysiology and histopathology of acute liver failure, usually you will find collapsed liver, shrunken liver. But if the acute liver failure is due to acute Budd-Chiari syndrome, which means acute thrombosis or acute occlusion of the two hepatic veins which drain the liver, this will cause congested liver, enlarged liver, tender liver. So if during examination you should note if you found enlarged or tender liver, immediately look to the hepatic venous outflow to the hepatic veins to exclude Budd-Chiari syndrome. If you found another clue is abdominal pain, vomiting, and diarrhea, you should think in amanita toxin ingestion. If the patient is a pregnant lady present with acute liver failure, acute fatty liver of pregnancy should be on the top of the list. Now to laboratory evaluation. In a patient with acute liver failure, you have also three targets during laboratory evaluation. Number one, to support your diagnosis, look for evidence of acute liver failure. So you will order for complete liver function tests, especially the really synthetic function, like prothrombin synthesis and prothrombin time and INR, and of course other liver enzymes, GPT, GOT, and so on. The second target is looking for the possible cause. So you should look for serology for acute hepatitis A, acute hepatitis B, herpes simplex virus, for other possible causes like autoimmune. You will ask for serology for autoimmune profile to diagnose autoimmune hepatitis like ANA, anti-smooth muscle antibody, anti-asthma, anti-smooth muscle antibody, anti-liver kidney microsomal enzyme, and so on, microsomal antibody, and so on. You may look for ceruloplasmin if there is a possibility of Wilson. You may look for ferritin and iron profile if there is possibility of hemochromatosis, and so on. So the first target is evidence to prove the diagnosis, evidence of acute liver failure. Number two, possible etiology. Number three, evidence of complications to assess the other organs. Is it limited to acute liver failure only, or other organs start to be affected? You will look to pulmonary function tests, you will look to renal function, serum creatinine, and so on. You may look to serum amylase and lipase to assess for pancreatitis, and so on. So the value of laboratory evaluation is to confirm diagnosis, to look for the possible cause, and to assess for complications. How about the liver biopsy? Actually, the cause, usually you can reach the cause from the history and the laboratory evaluation. To confirm the etiology, if laboratory results are inconclusive, we may need for tissue diagnosis and liver biopsy, but it is not a must in all cases. Only if we cannot reach the etiology from blood tests. In this case, we prefer transjugular approach is preferred. The usual approach for liver biopsy is transthoracic. The needle is given below the ribs, transthoracic approach. But because of coagulopathy in such patients and the high risk of bleeding, there is another approach. The needle for the biopsy will be introduced through the transjugular approach to take the sample from inside the venous system, so avoid external bleeding. Now to the lines of treatment. Again, we have three main principles for treatment. Number one, dealing with the possible cause. This may limit the severity, potentially prevent the progression from isolated hepatic failure to multi-organ failure. For example, if you prove that this is acetaminophen toxicity, you can give the antidote, which is intravenous N-acetylcysteine. Again, for acute liver failure due to hepatitis B virus infection, you may give the antiviral, specific antiviral, which is entecavir or adifovir. Actually, lamivudine is now a second line. It is not first line. It was before first line, but now the first line is entecavir or adifovir. If you found autoimmune hepatitis, so immune suppression can be used. If the cause is acute Budd-Chiari syndrome, we may give acute anticoagulation. Even we may put stent through transjugular intrahepatic portosystemic stent to resume the venous drainage from the liver and bypass the obstruction. If the cause is Amanita phalloides, you may give penicillin or salimarine. The second principle of treatment is supportive care, usually in ICU. This is to maintain the body systems and combat multi-organ failure. Actually, you cannot maintain the life of the patient for a long time on this supportive care. But the supportive care is aiming to limit the situation, to salvage the life of the patient, support the vital organs until either you can reach the triggering factor and give a treatment, allow for regeneration, or to prepare for liver transplant. But if you cannot reach the cause and you don't have liver transplant, this is a temporary measure that cannot maintain the patient for life, for a long time. So supportive measures include, if there is hepatic encephalopathy, admit to ICU, CT brain, frequent neurologic examination, endotracheal intubation for airway protection. If there is cerebral edema, increase intracranial pressure monitoring, head elevation, intravenous mannitol and hypertonic saline. If there is coagulopathy, you will manage either with vitamin K, fresh frozen plasma, platelet transfusion, and so on. If there is renal failure, avoid nephrotoxic agents, continuous veno-venous hemodialysis. If there is infection, you may make cultures, make low threshold for empiric antimicrobials. If there is any metabolic abnormalities, you will deal with accordingly. If there is hypoglycemia, or give glucose, hyperkalemia, or give measures for hyperkalemia, and so on. So this is almost symptomatic treatment in a trial to maintain until the final solution. The third and the most important principle in the treatment is liver transplant when indicated. This is the only definitive treatment for patients who failed to have a spontaneous regeneration. Early identification of those who will not recover is of utmost importance. Different selection criteria are used at different centers. For example, these are selection criteria of the Royal Free the King's College Hospital. If the patient is acute liver failure due to acetaminophen toxicity, you will look to the arterial pH. If less than 7.3, irrespective of the stage of encephalopathy, this is indication for transplant. Or if the PTT more than 100 seconds, or INR more than 6.5, and serum creatinine is more than 3.4 milligram per deciliter in patients with stage 3 and 4 encephalopathy. In non-acetaminophen toxicity, prolonged prothrombin time, more partial thromboplastin time more than 100 seconds, or INR more than 6.5, irrespective to stage of encephalopathy, is indication for transplant. So I would like you to remember that the INR is one of the most serious and reliable indicators of the functional status of the liver. On this INR, decision for liver transplant is depending on most of the criteria. On the other hand, if there is any of the following criteria, irrespective to encephalopathy, if the age less than 10 or more than 40, if the duration of jaundice before onset of encephalopathy more than 7 days, if PTT more than 50 seconds, and serum bilirubin more than 17.5 milligram per deciliter. Anyhow, the main idea is to look for the functional status of the liver and the real synthetic tests. Now to the future directions. Actually, there are other directions under research, like artificial liver support system now is the most potential. There is a machine like the hemodialysis machine, but it is very expensive. That's why you cannot maintain the patient for life on this machine, but it can be used for days or weeks until arrangement for urgent transplant. Bioartificial support systems utilizing hepatocytes pose a lot of challenges. Hepatocyte transplant and the stem cell are still under investigation. But there are more fruitful directions should be stressed in this moment. Fruitful directions, public health measures to minimize drug-induced acute liver failure. Not to take any medication without prescription. This is to avoid drug-induced liver injury, which is responsible for most of cases in the developed world. In the third world, vaccination, in addition to minimizing drug prescription, vaccination against hepatitis A, B, and E viruses has a good role in controlling such a case. Thank you very much.